So I wanted to also announce about that new Odell book that I have just recently shared in the group today. So the March candidates, obviously because they've read all these months the old Odell, so they should not be starting with the new Odell. But I think because now we've got extra cases and also some chapters have been updated. So for the September candidates, because you've only recently started, it's been only a week that the course has been officially started. So my recommendation would be to read from the newer Odell. And in fact, I would from the next cases also in the roster, I shall have a look and I might also start taking the cases from the newer Odell in the class. So that would be my recommendation because we have an updated edition and there are newer chapters which also include newer topics. So anyways, those topics are also important from the exam point of view. So I shall continue reading the newer Odell also. I'll take another day or so and I'll give you more insights on that. But for September, I would recommend that if you haven't started much in depth of Odell, then I would recommend doing the newer ones. Even in the March batch, if somebody wants to do the new Odell, then it would be advisable because you have an updated version, you have an updated edition, then there's no denying that you should be reading that. And about setting the paper from the old one, so it is always added information. On Odell, TG is the one which has more fact-like information and much more like a guideline. Odell is not a guideline, it's more like a clinical discussion. So newer the edition, better the discussion, more the topics discussed, better for your preparation in the exam. So from preparation point of view, I would advise that those who can read newer Odell should start doing the newer Odell because I would be also starting taking chapters from newer Odell from the next class. And also there are about 9 new chapters in new Odell. So I will also see if any of those are extremely important, then I would also incorporate them in the classes. And if those topics are somehow which you can manage by yourself, then you would continue doing them on your own. But if they're extremely important, like I feel that definitely there is going to be something in the exam from them, then I would try to accommodate that in our class. And also because we know most likely that exam might get delayed, so we can maybe stretch out our roster also a bit, but that would only be this time. From the next year, obviously the time for preparation would be restricted and limited, so I'll also have to accommodate in the given 22 to 23 week time frame. This time we can take that liberty and do those extra classes. But my honest advice is those who can, please do the newer edition. At least for the March guys, you don't want to read the entire Odell, new Odell, but do those last 9 chapters that they have added, the new chapters, please do those at least. In the classes from now, I'll be taking the newer Odell cases. Okay? So today we'll be doing from the old edition, and from the next class onwards means we'll switch to the newer edition. Okay. So let's continue where we left off with the 1000 file, which was question number 480. So a patient with reasonable oral hygiene has a small proximal caries on the premolar. So there's a small proximal caries on a premolar. The patient requests anesthetic filling. Your preparation will be extending to what level? So if you have a proximal caries only on a premolar, then instead of going all the way and extending for extension for prevention principle is applied for your amalgam and not for the composite restorations. So if you're doing composite restoration, the bonding of the composite would be achieved with the etching and bonding agent on the small cavity box only. So we would still do the PRR, preventive resin restoration. That would be minimally invasive preparation of the cap caries, and thus only proximal caries removal in the proximal surface, on the proximal surface with occlusal and gingival bevels. Bevels will give you slightly more surface area and thus would aid in more retention. So extension for prevention and complete extension into the occlusal cavity for the retention is obviously not required with your composite restoration, which would be required for your amalgams. So if it's only you're doing it with your aesthetic filling, that's your composites. So you do not require the same amalgam preparation principles. You can just do with your proximal caries removal, minimal preparation, and thus only giving bevels for added retention. Which of the following is the most significant factor regarding the filler in composite for increased strength? So in the last class also, I talked about the filler component and the resin component. If you remember, we talked about how the physical properties are different and how they both contribute in a different manner to your composites. Like filler gives you physical properties and your resins give you aesthetic properties because they're more malleable, they're more plastic, they're more pliable, and which can be easily adapted. And then they also set with curing, and they also provide that translucency or the aesthetic effect to your natural tooth shade. But here it is asked regarding the fillers that what is the most significant factor in regards to fillers only in composites for increased strength. So we know that fillers incorporate the physical properties which include strength, but what part of the filler contributes more? Is it the size, the volume, weight? What is that? So in each hybrid, microfilled, macro, small particle, there are difference in the weight or volume, and there's difference in the size as well. So size also contribute because larger the filler, it would have much more higher strength. But larger particles have one drawback. Larger particles of filler, when the composite is polished or is finished, the entire particle will be removed when it is embedded in your composite. So when you are polishing from the top surface, if a larger filler particle is removed, the void that is left behind is also larger. So your superficial surface would not have smoothness, but it would leave larger voids behind it. Whereas if you have a smaller particle, the size of the particle is smaller. First, you can incorporate many of the small particles compared to the large ones. So your small particles could be more voluminous, can be more in concentration per unit area as compared to your large particles. And also with polishing, the voids that the small particles leave behind are smaller, which are easily blended microscopically on the surface of the resin. So basically, they're more polishable. The small particles, they add to the translucency, they add to the smoothness of the finish. And plus also because they're more in number per unit area, so higher concentration of the filler particles gives much more strength as compared to the less volume per unit area. So it's more in the size, it's the concentration of the filler particles per unit area that contributes to the strength. We need much more concentrated filler particles than larger particles because they are going to be giving you the end result also non-aesthetic and also not much strength in terms of per unit area how much filler is going to be. So that's why nano-filled, nano-hybrid, they are most preferred when you're looking for posterior composite solutions because they come with small particle, nanoparticle size, and also comes with high volume or the high concentration of fillers in that particular unit area of the composite. So that's how it is going to give you higher strength as well as also surface finish or the surface smoothness is also going to be superior. A patient who has a small incisal fracture on the maxillary incisor, what would be the best material to resist the fracture at the acid-etched tooth composite interface? So if you are trying to restore it with composite, this was a fractured fragment and it is incorporated a little bit of incisal edge also. So it's an incisal fracture. And you're going to restore it with your composite buildup. So what kind of material would you prefer? So like we discussed, microfill has more resin, less filler. It would give you much more translucency, much more layering and much more absorption and the optical properties similar to your natural enamel. And hybrid, because it contains more fillers, it would not be as translucent. It would be much slightly opaquer than your microfill. and it would also have superior physical properties because of higher concentration of fillers. So because we are dealing with a fracture which involves incisal fracture, and we are not just doing a complete labial surface veneering with composite. So both of the demands or both of the procedures have different demands from your material. One is, suppose you were doing a labial veneer. It was a labial veneer with a composite, right? So entire structure of the tooth is intact. On that, for aesthetics, you're giving a veneer. So the strength part the tooth has. Aesthetics you want to give. So when you want to do a laminate with composite and you want to get that translucency or the enamel layers, which one would you prefer, hybrid or microfill? So when it comes to aesthetics, we'll go with microfill. But here, because you have a fractured component and you're building it up, and because in this part where there is no tooth structure, you're also building the inner dentinal layers with your composites. And that structure, which needs to incorporate the incisal surface, incisal edge, and also this much part of the bulk of the tooth, requires strength more than it requires your aesthetics. Yes, the topmost layers can be used. Definitely, whenever you are building up a composite, you're not always dealing with just one composite. You're not always using, you can't build up entirely in microfill, you can't build up entirely in hybrid. You definitely always require layering when you're dealing with composites, because each composite and each filler quantity imparts different properties. I mean, something gives you more strength, but inferior aesthetics. And the topmost layers where you want enamel, and then you use your microfill, which gives you best translucency, but it would not be the best to give you the strength. So because you have a fracture, your main concern would be to build up, would be for strength. And in that case, the predominant composite that you would use to form the base would be hybrid. Only the top layer can be given with your microfill composite for your aesthetics. But if it was only about a laminate to restore the enamel layer or give aesthetics, then microfill is of choice. So here, because you need strength more than you would need the translucency, that's why hybrid composite is your answer. Now, while doing an RCT, you gave a dressing with a paper point, which was wetted with a certain intracanal medicament solution. So the patient arrives the next day with severe pain, right? So there was this RCT treated tooth, it was an infected canal, you wetted your paper point with a certain intracanal medicament and you inserted it into your canal and sent the patient home. Next day, the patient is showing you signs of inflammation. There is severe pain associated. It could have been an inflammatory reaction to that agent that you gave. It could have been some debridement, incomplete debridement, some necrotic substance left behind. But we cannot be sure of that, but we gave this paper point wetted with a particular solution, and the next day patient arrives with the pain. There is no swelling, but tooth is tender to percussion. That means there is a periapical reaction. So periapical reaction immediately the next day is most likely due to percolation of that intracanal medicament that you put there, which also brought about a reaction in periapical area, leading to tenderness on percussion, because percussion is the sign that the periapical area is irritated. So how would you do, or what would you do to manage this situation? So you are not going to replace with a similar dressing, considering there is a high chance that this reaction is coming out of that medicament that you put there with your paper point. And replacing or prescribing antibiotic also is not an ideal situation, because even if it's your remnant of some noxious necrotic pulp, then also you require it to be completely debrided. So ideally, you should take out this paper point, debride the canal, irrigate it, even if there is some necrotic elements left behind, that also gets eliminated, and then you replace that dressing with a corticosteroid base, because there's an inflammatory reaction now. So use paper point or any other lanceolospiral to inject or to put the corticosteroid intracanal medicament into the canal and also slightly into the periapical area to subside that inflammatory reaction that has been set up by this agent. There is no need to retrieve the paper point surgically. There is no surgical requirement. Paper point can be easily tweezed out. There is no surgical intervention required. Then removing the dressing and leaving for several days before replacing it. If you remove the dressing, but the periapical inflammation may not subside, it is acute, and the patient would want immediate relief. So then giving some anti-inflammatory agent would be a better choice than just leaving it as is, especially for several days before replacing it. And IND is also not required. INDs are mostly done when you have pre-op. Before you start your RCT, then you have a pre-op swelling. In most of the cases, then IND would be required. In the Friday class, when we continue and do more of these endo MCQs, I'm going to read from Volkin on that day, Friday. So Diana, if you're here, you can remind me that as well. On Friday's class, I'll take brief 10 to 15 minutes and we'll discuss the endodontic emergencies as we spoke about also in the previous class. So it would be your pain situations, swellings, and flare-ups before you start your RCT, inter-appointment, and after completion of your RCT. We'll take that topic from Bolton on Friday class. So I'll also tell you more in detail in what situations INDs are indicated and in what situations INDs not be performed. It's an inter-appointment flare-up. For you to understand, this is an emergency. Patient has come back next day with pain. But this is not before you started, this is not after completion of complete RCT. This is inter-appointment flare-up. Inter-appointment flare-up can be because of some noxious substances left behind or because of some medicaments that you have inserted, any reaction to that. There is no swelling in response to it. Even if there was a swelling, it would mostly be because of a necrotic leftover. So the ideal management is debride the canal, irrigate it well so that whatever irritants are there, they are flushed out, and then you just give an intracanal dressing or just give a closed dressing and maybe just ask the patient to take a stronger analgesic. That's all. Antibiotics are not required in this situation in inter-appointment flare-ups. You do not require them. So we'll deal about it. We'll talk about how to deal with such emergencies more on the Friday class. The best method of cleaning and toileting a cavity is ideally when you prepare a cavity for restoration, for direct restorations, the best way to clean them is with water. Alcohol is a desiccant. Citric acid was advised, or sometimes is advised to root condition when you're doing your scaling and root planing, and then you want the reattachment. It was believed that it favors the formation of the newer cementum and your newer periodontal ligament fibers, but as per Calenza, it has not found to be true. So studies have indicated that both the treated teeth which were treated with citric acid and not, after successful completion of scaling and root planing, subgingival root planing, they responded equally. So citric acid treated roots or citric acid conditioned roots did not give you any better periodontal attachment than non-treated ones. So it is not used for cavities, but sometimes earlier was used for your root treatment. Again, an organic acid is also not required. It's only your water that you should clean your cavities with. One more thing that you may use only, but when you're using your GIC as your restoration, is you can condition your dentine by using your polyacrylic acid. But that is not for cleaning and toilet of cavity. That is the dentine conditioning. It is conditioning of your dentine, opening them, widening them so that your chemical penetrability of GIC is improved. So only with GIC you treat your dentine with polyacrylic acid. Otherwise, when you're doing amalgam or composites, the cleaning of the cavity for the leftover tooth structure debris that was removed is only through your water. And you should not dry off your cavity through your air blast, but rather only use your cotton pallets to lightly pat it dry and swab with your cotton pallets. Not use your air blast because that leads to retraction of odontoblast into the dentinal tubules, which can be even permanent. Then periapical abscess is differentiated from periodontal abscess. So we know a periapical abscess is coming from a non-vital canal and a periodontal abscess is coming from a deep periodontal pocket which got obliterated on top by plaque and calculus, and underneath the bacterial products, the bacteria, which continue to degrade and regranulate the periodontal tissues. The pus is released, and this pus initially was having a vent, but because the pocket top got obstructed and obliterated by the plaque and calculus, now it has become, the pus is getting accumulated and it has become a swelling. So this is also a swelling, but it is because of periodontal pocket, which got obliterated, and now the pus is accumulated. So it is associated with your periodontitis, but not with the non-vital pulp. If it's not a very deep pocket and there is no accessory canal here, that this infection can reach the pulp through those accessory canals, then this is your true periodontal abscess. There is no pulpal involvement. Whereas the one coming from a non-vital pulp, in the periapical area, because of the destruction of lamina dura and the bone, now the pus is accumulated here, but it can tend to spread on the facial surface and can again give you a swelling on the labial sulcus. So both can be seen clinically as labial sulcus swelling. It can be a swelling on the labial gingiva. Then history is still not important, but vitality test would definitely be different for the bone, because the periapical abscess is definitely coming from a non-vital pulp, and a periodontal abscess in its true sense, yes, it can later involve endodontics. It can involve pulp with infection through your lateral canals. That would be but your perioendo lesion. It would not be a true periodontal abscess. So a true periodontal abscess is only accumulation of pus in your periodontal pocket, and thus comes from your truly vital pulp. There is no response, there is no contribution of the infection or non-vital pulp into that abscess. Upon X-ray also, this can appear similar, because your endodontic abscess can also disrupt your bone labially. So it can give you this radiolucency present on the lateral surface of the wall instead of completely being in periapical area. So it can give you a lateral spread. It can look like a deeper periodontal pocket. So even a periodontal pocket can extend periapically. So these can have similar radiographic appearance. These can have similar clinical appearance in terms of pain. When you press the gingiva, or when you press the labial attached gingiva where the swelling is present, it could give you the similar clinical features. It would be similar swelling on the labial attached gingiva. Radiographically can also be similar. Pain can also be similar. But what would be different, especially in initial stages when there is no lateral or retrograde pulpal involvement through periodontal lesion, till that time, the periodontal abscess tooth is going to have and give you vitality response. Whereas the periapical abscess will not give you vitality response because it's coming from a necrosed pulp. So vitality test is always the best answer or the best solution or best way to differentiate a true periapical abscess from a true periodontal abscess. A patient suffers a blow to their maxillary central incisor, but there was no fracture. So if there is no fracture and there was a blow to a tooth, so it's a concussion, there was no subluxation, there was no luxation, there was no movement displacement. So if there's concussion, it was a severe blow, no fracture, then most likely the tooth becomes non-vital. It would not be immediate necrosis. The pulp would start showing the reaction slowly, but it would become non-vital irrespective of the treatment. It will only become non-vital if treatment was delayed. There is no treatment per se for this tooth. Prophylactically, you would not start RCT unless you get signs of your necrosis. So that's why there is no treatment for the same, because it has not been mobile. It is only concussion. There is no luxation, there is no subluxation, there is no mobility, there is no displacement, there is no fracture associated with the alveolar socket wall. So no treatment required. So this treatment doesn't make sense that it will become non-vital only if you delay the treatment. There was no treatment required at that point. We have to just wait it, and eventually, because pulp took all the brunt of the trauma, it will go under necrosis, most likely. No changes seen if fracture does not occur, that happens rarely. So mostly pulp taken brunt would become non-vital irrespective of the treatment. The pulpal floor of the class 2 cavity for a mandibular first premolar. This was the first question when we started this file. The buccal and the pulpal horn heights are different. So whenever you're creating a cavity, the floor has to be lingually tilted. It is not parallel to your occlusal plane. You may think that this is your occlusal plane, but this is not occlusal plane. This is occlusal surface of this tooth. There is a difference in occlusal plane and there is a difference in occlusal surface. Each tooth has its occlusal surface. Occlusal plane is what is between maxilla and mandible, all the teeth. That's a constant plane. Not all teeth occlusal surface is parallel to the occlusal plane between maxilla and mandible. So maxilla versus mandible is the occlusal plane. Each tooth has an occlusal surface. So the occlusal plane passes through the cusp tips on the premolar would be like this, but the occlusal surface is lingually tilted. So occlusal surface is not parallel to the occlusal plane of the mouth, and that's why our floor is parallel to the occlusal surface, but not parallel to the occlusal plane. So that's why A is not correct. And it's also not perpendicular to the long axis of the tooth. So that's why B is also incorrect. It is tilted lingually. Marginal leakage seen at the proximal surface, gingival cable surface of a recently restored class 2 can be caused by. So let's imagine what it means to ask here. Right? If this is the tooth that you're restoring, it's a class 2 cavity. So this is the occlusal component. And this is your proximal box. So micro leakage at the proximal gingival cable surface. Proximal gingival cable surface is this. This is your proximal wall. This is gingival seat. So this marginal leakage at this point where you put your restoration can be because of. So let's look at it. Let's try to imagine in what situations we can have discrepancies and gaps at the margin here when you're putting a proximal restoration. If you did not condense your amalgam sufficiently, absolutely correct. Whatever the material, your composite or amalgam, if you're not condensing it well, adapting it to the surface, you may be leaving gaps in these surfaces. Absolutely makes sense. First proximal increment was too large. When you put a large material together and then you try to condense it, the chances of creating voids is higher compared to when you put smaller increments, which are more easily adapted or rather well adapted with your condensation. So the increments should be smaller and not too large. They can also lead to voids and thus give you marginal leakage. Neglecting to wedge the matrix band. So because for your proximal cavity, you would have placed a matrix band here, which would try to give you the recontour of the proximal wall. And to make sure that condensing forces are not pushing the material out from this margin, you have to wedge it also. So wedging is done to adapt the matrix band to the tooth structure and also try to create separation between the edges and teeth so that your thickness of your matrix band is also compensated for. If you do not put this wedge here, and even if you used your normal forces, there could be slight extrusion because there was no force here which was trying to closely adapt it. So condensing forces would extrude your material out. You will get an overhang here. And plus, when you take out that matrix strip or matrix band, because the separation was not achieved, teeth will not go back together and will not achieve a close contact with adjacent teeth. So this thickness of the matrix band would be left behind as a gap. So matrix band thickness is compensated for by this separation of the teeth achieved by wedging. It separates the teeth. Once you take out the wedge filling is done, you take out your matrix band, then that separation is also dissolved and the teeth come together. And then the thickness of the proximal band or the matrix band is compensated for. So you're not left behind that thin gap of microns, which can lead to further food impaction, lead to your periodontal destruction. So when you neglect to wedge the matrix, you either get periodontal problems because you're left with gaps, or here at the proximal cavo surface between gingival seat and the proximal wall, there would be an overhang. There would be an overhang. You will have restoration extruded out. So that would not be gap, but it is an overhang which can retain plaque and give you periodontal destruction. But it would usually not give you marginal leakage because it is an excessive material, not deficiency of it. Micro leakage is seen associated with deficiencies or gaps, not with excess overhangs. So neglecting to wedge the matrix is wrong. It will give you gap on the marginal ridge surface, will give you overhangs, but it would not give you marginal leakage. So 3 is not correct. Then hand manipulation instead of mechanical. As per your Sturtevant, hand manipulation is superior to mechanical, so it should always help in closer adaptation, not lead to marginal leakage. So hand manipulation is superior than mechanical, so 4 doesn't make sense. And also Dinah, if you're putting the list for today, please share the first reference, Sturtevant reference, that hand manipulation should be done and mechanical is not preferred or should be avoided. Even so, I saw this question on this chat. No, saline is not used for your cavity cleaning. I've not seen saline to use your cavities when you're preparing them. Saline is used in your live tissues, it is your enamel and dentin, so you're not using saline. It is not the soft tissue. So in your peripical surgeries, yes, you can use saline to clean that area, but not cleaning your cavities or restorations or the cavity preparations. No, even when given as saline, water is the one that you use. So debris contamination, if you were adapting it and there was debris contamination in the proximal surface, between the proximal surface and between the restoration, so because when you adapt it closely, the debris would still be accumulated there. After removal, when the patient is gone off with your oral hygiene, with your chewing, all the forces acting, the debris would be removed. And when debris is removed, it leaves gaps and voids again between the tooth and the restoration. So again, that can also lead to gaps and lead to micro leakage. So 1, 2, and 5 would lead to micro leakage and gaps. 3 will give you overhangs. 4, in fact, is a superior method to avoid marginal leakage, right? So 1, 2, and 5 is correct here. And that would be all for today that we discussed this file. And Wednesday class also, I'll do more pages, 18 and 19. Yeah. All right. So that would be it for the MCQs in today's class. And let's go to Odell now. So Dinah, please remind me, I have to share this added notes file on the group after the class. The solved endo file with more notes. And let's start the case of gingival recession today. Yeah, Aline, I'm reading out your question here. Aline has a question. How about if you don't put the wedge in a good place and overhang is there, when you take out the matrix and it breaks, it will be void as well. Well, if that happens, Aline, then in most of the cases, the entire proximal restoration may also come out of it. So we are still, that is why that is also one of the possibility, but that would not be a micro leakage case. That's like a complete fracturing of the restoration. So we are talking about the situations here which actually give you just enough gaps to not fail the restoration. It would not be a fracture of restoration, but yet give you the gaps which can lead to micro leakage and development of secondary caries, right? So if it breaks, it would actually be breaking the major chunk and you would be repeating that restoration. You would not leave it off as a micro leakage, right? So that is very difficult to be missed out. Those debris contamination and the voids because of your large increments are easily missed out. And from the top, you might think that it's the best looking restoration in the world, but it would be coming with your gaps and discrepancies. So if you're taking the matrix band and usually it breaks out the restoration, that can be easily appreciated. And usually the whole proximal box comes out of it, so you would be repeating that restoration. Yeah. So hope that answers your doubts. So let's move to the Odell case discussion. Now with the perio classes also, what there is this thing that when I start teaching you perio, so even when we go to the 1000 MCQs today, we are starting with the gingival lesson, and it is going to be the first perio lesson actually. So there are various grafting techniques, and then there are various treatment modalities, surgical treatment modalities in perio. So if you really wanted to do it as a one class, then we can actually totally dedicate entire one class to it. So that's why I can't be teaching you 2 Odell cases and all the perio surgical modalities together. That's why what we do is, instead of doing all the cases together or all the surgical methods together, we do it as it comes as a question. So we start with recession. In this one, because they have done a free gingival graft, I will be teaching you in detail about a free gingival graft, a little bit on the connective tissue graft as well. But as we start the perio questions and more questions on the grafts keep coming up, then I'll explain each grafting technique with each question. And once we are done discussing all the grafting technique, then we'll have a quick session, maybe 10 minutes, 15 minutes to revise all those techniques. And I'll rather also give you some articles where you can revise all those techniques together. Yeah. So for now, we'll only dedicate and do as and when we come to each technique.